And without ado, I shall go on to my talk. Very good evening to one and all of you. I thought I'd go on as the first batsman in this wonderful series of talk. And my due is to deal on the pearls to hit target emmetropia. I suppose it goes without saying that success is how well you hit the target. In other words, what it actually tries to tell us is how happy your patient is with the distant vision, the intermediate vision, or the near vision, or a combination of both which you promised, and how well he looks at you as a success. And believe me, hitting the target in all of these patients will definitely take you leaps and bounds in your practice. So the next question which comes is, how well are we performing? So then, how well we are performing is the next issue which we need to address. Until some time back, when we were with the third generation formulae, 75% of our patients are well within plus minus 0.5 diopters, and we thought it was acceptable. And these were actually getting worse for unusual eyes or complex eyes. But today, with the fourth generation formula, the fifth and more, we have 90% of our patients who are able to achieve within plus minus 0.5 diopter of target emmetropia, and that seems to do well even in these unusual eyes. When we talk of biometry, it apparently looks to be a simple arithmetic, but then we need to understand that there are a lot of measurements and assumptions which happen here. That when we talk of an IOL power calculation, the values which need to be incorporated is the axial length, the keratometry, and the effective lens position. Of course, the post-op diffraction, but the one place where we are near perfect is the axial length measurement. But we are sort of flummoxed with the assumptions which are made with the effective lens position and the K value. So then, how did we go about it? Like if this was a particular case where the patient had perfect 6, and 6, it was perfect measurements and a perfect formula. Is it that there were two errors in this particular formula which canceled out each other? Then you thought you have an answer here, but then you suddenly land up with this kind of a residual refractive error. And with all the promises you've made, you need to have your right answers. So what happened way back in 2008, they found that the effective lens position was a causative factor in 35% of the cases for residual refractive error, the axial length in 27%, the refraction in 17% and more. And then now that we know that we are bang on accurate in majority of our situations with the axial length, with the kind of biometric measurements which we have, and also the fact that we are right with our incisions and our CCC, and the fact that we are nearly able to identify the position of the lens in the capsular bag, we are pretty bang on in our getting to that emmetropic target outcome. But then again, the challenges which continue to remain are the K value and the effective lens position. So does it mean that one formula fits all? Maybe, yes, we could try with multiple formulas for different scenarios, but today, with the fifth generation formulas, the Barretts, we do understand that we are able to address this in majority of our situations, if not all. We have evolved through the regression formula, the Vergence formula, which was defined with the Gaussian optics, with the different variables which they used to address the effective lens position, and the artificial intelligence and the statistical model, which essentially incorporated a whole lot of post-refractive results to get that kind of effective emmetropic outcome. And the ray tracing formulas were definitely a way forward. But what actually still challenged us, that if the lens sat a little anteriorly in its position, you need to implant a lower IOL part than required. And if it sits a little posteriorly, you need to implant a higher IOL part. And those were the very minuscule challenges which challenge us. However, in normal eyes and normal corneas, we are able to get away with the average regular formulas and are not feeling challenged. But the challenge comes when we are in a situation like a long eye. However, in a long eye, by the very fact the IOL parts being of lower part, the impact on the effective lens position and the refractive outcome is not significant. The only problem is, in majority of the formulas, we tend to overestimate the axial length or the length of the eyeball. However, the challenge becomes entirely different in a short eye because of the high-powered IOLs which are used, and even a minuscule shift in the IOL power could end up with a very big refractive change. In fact, we are not sure whether it's a normal axial length, a normal anterior chamber, a smaller anterior chamber. We are not sure whether it's an increased length thickness, which makes it appear as if it is a smaller anterior chamber depth. Again, if you look at the dimension matrix of the human eye, what you realize that in 73.4% of the eyes, the anterior chamber depth and the axial length are normal, whereas the axial length is short in 6.9% of the eyes. And there are 1.8% of the eyes where both the anterior chamber depth and the axial length are small. There are eyes which have a normal anterior chamber depth, but have a long eye in 13.5% of the cases. And in 1.5% of the cases, both the anterior chamber depth and the axial length are long. So what we realize is there's a whole range of combinations which can present. And towards this, the average formulas work well in most of these normal eyes, but it is these newer formulas which seem to perform well in these extremes of axial length. The other thing which we need to look at is the toricity ratio. Like an average toricity ratio 1.45 seems to do well for most of the toric IOL implants. But if it is an eye which has a short anterior chamber depth or a larger anterior chamber depth, the effective lens position assumptions are definitely challenged. Like you can see here, for a normal eye, you need a T5. For a small eye, you need T4, and for a large eye, you need a T6 toric IOL. Now, that is where the kind of accuracy is challenged. When you look at the Barrett universal formula, you realize they come up with 5 variables to predict the effective lens position of the eye. We need to know that these are based on thick lens formulae, and what it does is it is able to tell you exactly what is the position of the IOL in the bag, that is where the lens factor. It tells you about the different changes in the lens, effective lens position based on the different principal planes of the IOL. It tells you whether you need to place a with the rule IOL astigmatism or you're dealing with against the rule astigmatism. It tells you whether you're going to use a Barrett 3K formula, and it uses double K solutions. In other words, the Barrett suit seems to give you a convincing answer for a routine situation for a toric IOL implant and a post-refractive surgery eye. Now, the challenge is it also tells us that with the changing geometry of the lens, you could be normally using a biconvex lens, but as the powers change, you may go on to a plano-convex or a meniscus lens, and it tells you how the effective lens position or where the IOL sits in the capsular bag, that is the distance from the anterior corneal surface to the optical center of the IOL, where it is exactly placed, could also be defined with the help of this formula. So essentially, you need to have key strategies for better measurements. And the Pearl 2 tells us that we have a range of optical biometers, but we still are doing well with the immersion biometer. The only advantage these optical biometers give is the high frequency of the laser beam, which brings in a great accuracy in our measurement techniques. And the average difference between an ultrasound and an optical is as much as 200 microns. If you're using an immersion biometer, you should concentrate that all the spikes are of equal amplitude, that you're not pressing too much on the cornea, that the standard deviation is within 0.6 diopters. If it is a cornea, we need to see whether it's just a normal cornea, whether you're accurate in your measurements, even if it is an abnormal cornea or the cornea which has been modified surgically. And we have a conglomerate of technologies, like some measuring a 3.2 ring, some like an IOL master having 3 rings to measure the K value, or a lens star which has 2 rings to measure. So further on, we have today the IOL master 700, which takes in information from the anterior corneal surface and the posterior corneal surface and gives us the total arithmetic value, which, if incorporated into the Barrett formulas, gives us the Barrett's toric TK, the Barrett's TK treatment, and gives us all the ranges of formulas. But if again, you're using this total characterometry into those other formulas which have already devised a mathematical model of arriving at the posterior corneal astigmatic measure, we need to be cautious because you would end up doing an overcorrection. When you're looking at the IOL Master 700, there are, besides a swept sort OCT, it has a B-scan biometry wherein with the help of both, it measures the corneal thickness, the lens thickness, the fixation check. And what is most important is always measure both eyes in every patient, because herein you find there's a difference in the axial length, and you realize that the IOL part calculation values are different in different formulae. Then you immediately like to look at the immersion biometer. You try to remove all the outliers and see whether you are using the average formulas and average values. You see whether the standard deviation is well within normal limits. And then if you try, supposing going back on the day of surgery and repeat an IOL Master 700, you realize that that error, which was earlier on because of the dense PSC with the other optical biometer, has been nullified, and you get similar values in all the different formulas which are using. It is also important to remember that an axial length difference of more than 0.3, a K value of more than 1 diopter, or an IOL power of more than 1 diopter, please beware that that could be an error. So you need to evaluate the quality of your raw data. Like in this particular case, there was a difference of 2 diopter of astigmatism between the two eyes. And when you examine the eye carefully on the slit lamp, you realize that this was a severe dry eye status. And then when you treated the dry eye and then go back and do your measurements, you realize that astigmatism is similar magnitude in both eyes. And if this was not factored in, your IOL power calculations could have been wrong. In fact, 60% of our routine cataract patients who look asymptomatic have a tear breakup time of less than 5 seconds, and 50% of them have central corneal staining. So what you realize that the impact on the dry eye disease can give refractive surprises because of the tear or hyperosmolarity changes can bring on an IOL power difference of even more than 0.5 diopters. So you need to explain to your patient beforehand that he has a dry eye disease. You need to treat it rather than being challenged with a symptomatic patient post-cataract surgery. You need to teach your technicians to look at all the LED points, whether it has a fishtail appearance, whether it's in the red or yellow or green, whether the standard deviation was less than 0.2, whether the signal to noise ratio was more than 2. Like these are small issues which become big issues when you're looking at exactitude in emmetropic outcome. So you need to validate your measurements. Like this particular patient had a K value which were different between two eyes. And only then when you dig into your patient's history that he tells you that he had a LASIK surgery done 30 years back. And if he had not factored it and changed your IOL formulas, your IOL power calculation would have been challenged. There are different validation guidelines which come on you in your when your errors, when there's a astigmatic change, when the AC depth is different, when the axial length is different, and all of these have to be looked in carefully. When you're treating astigmatism, it tells you whether it's a with the rule astigmatism, whether it's non-toric IOL, whether it's against the rule astigmatism, and that you need to implant a toric IOL. And this was a particular case wherein the astigmatism was not significant. This was a particular case which tells us that it makes sense to actually do a keratometry before you start counseling your patient, because if he has a toricity, you could actually straight away go on to correcting the toric IOL and take your counseling in that direction. Pearl 7 tells us that when you're doing a multifocal IOL, the threshold for astigmatism is so low. So even if it is a low diopter, and if you're on a femtocataract platform, it makes sense to use those arcuate keratotomies. Now, this was a particular patient who was being planned for a toric IOL. He did have a 0.8 diopter of astigmatism, which was overlooked, and a PanOptix was implanted. And this patient had a small amount of astigmatism, was not happy, convinced him that we would do a laser touch-up after a period of time, and went ahead and did a PanOptix toric and the other eye, looked into all the factors, implanted the right series of toric IOL, and found that this patient with the laser vision touch-up in the other eye and the other second eye with the PanOptix torics did well. The Pearl 8 tells us that you need to understand what is it your toric IOL calculator does. Does it measure the posterior corneal astigmatism? Does it look into the toricity ratio specific to different axial length? Does it look into the centroid values? Because if you only looked at the magnitude of the astigmatism, it would tell you that there is this SIA is different. But if you look at the axis, you will find that the axis actually cancels out each other. And overall, what we understand that for any incision less than 2.8, the centroid value, 2.4, the centroid value was only 0.1, and that is all needs to be factored. If you have an immersion biometer, you could still feed in all the data from the immersion onto the toric online formulae. But only thing you need to be specific is you add the acoustic factor of the IOL constant, and it would tell you what is the axis of placement, what is going to be a residual astigmatism, and how close to target emmetropia you should have. There are certain unusual measurements in unusual eyes, like 70% of the eyes, you're fine with your average formulas. But sometimes you would see you have a dry eye status which needs to be addressed. Some of these patients, you need to do a tomography, need to understand the posterior corneal astigmatism, need to understand whether there's an irregular astigmatism, whether you need to use specific formulae. You would find that in a post-LASIK eye, you need to look at the higher order abrasions which are induced in these eyes. Would these patients do well? Is the angle alpha within normal limits? Whether this patient would do well with a premium IOL, whether the astigmatism is orthogonal in these eyes, whether the symmetry of the topography is normal. You have looked into range of values, but then you need to understand that yes, the optical biometer seems to be doing the best, but you need to verify the raw data at all times. You need to validate your measurements. You cannot remove yourself from the process of IOL power calculation, even if your optometrist is doing extremely well. You need to ensure that you're using the right choice of formulae. You need to treat the astigmatism. And believe me, if you have the right IOL and you have combined it with perfect surgery, you are bang on. But yet there's one small sorry tale, that effective lens position is seen to shift post-operatively too. And this was a study which tells us that the anterior chamber depth can shift for by more than 1 millimeter from 1 hour to 2 months. So in other words, you think you have nailed the ELP, which is the challenge for target emmetropic outcome. And this could actually change as the patient heals. And this is where you're stuck. This is where you're waiting for a breakthrough technology, which gives us that final answer which we need in our post-op IOL power adjustment tool, so that we are just where you need to have a target emmetropic outcome in every single case of ours. Thank you. Now.
Thank you, ma'am. That was a very, very nice presentation, ma'am. I have one question. A lot of us have IOL Master 500 and that doesn't give you the posterior curvature measurements. How important is posterior curvature measurements? Would upgrading to IOL Master 700 give a better patient satisfaction? What are your thoughts on this?
Definitely incorporating the posterior corneal astigmatism, either by directly measuring with the IOL Master 700 or going in using a Barrett formulae, which has its own mathematical model for calculating the posterior corneal astigmatism. It is at what level? I mean, you need to understand, you could even use an immersion and use all its values and feed in online onto the Barrett's formulae. With the acoustic IOL constant, you could still do pretty well if your surgical steps are doing very well. If you have access to the IOL Master 700, yes, it definitely brings in that amount of precision in your end outcome.